Hey guys, Chris Garrett from HealthQuest Physical Therapy and the Overhead Athletic Institute. Today what we're going to talk about is the thoracic spine, some implications in terms of pathology and the throwing motion, and ways to self-stretch it at home. Alright, so before we get to some of the self-stretches, we first have to talk about some of the pathology and anatomy pertaining to the back as a whole. So in the back you have three areas. You have the cervical spine, the thoracic spine, and the lumbar spine. Cervical is the neck, thoracic is the mid-back, and lumbar is the low back. So generally what you see is cervical and lumbar pain, disc degeneration, and an origin of pathology starting there. The structure of each vertebrae, and they're all framed a little bit differently as you go down the back, but generally there's a vertebrae, then there's a disc, then there's another vertebrae. So for example, if on an X-ray and MRI you saw C5 through C6, what they're talking about is the C5 disc and the C5 bone and the nerve roots on either side. So we would call that the C5 motion segment. So historically, the neck, the lower neck, C4 through C6 motion segments, and the low back, L4 through L5 motion segments are usually the source of pain and breakdown. So think of the disc like a donut. The outer part is tough and the inner part is jelly. The outer part, his role is kind of like a ligament. It provides stability for each joint, just like the joints or the capsules on the other side of the spine, which I'll show you in a second. And then you have the inner part, the jelly part, which is the nucleus, and that is more for shock absorption. So what happens over time, and this is a normal thing, is you get a little breakdown, little tears in the outer part of the disc. So these outer part of the disc, that creates an instability at that region. So what you normally see is maybe some clicking and popping, some locking, some increased motion at those areas. And what that does is that inner part then can work its way out, and that's what we would call disc degeneration. You can get a herniation from that. So you usually see that starting early, depending on your lifestyle, genetics, things like that. And then as we get older, 30s, 40s, 50s, those are more hypermobility, where that disc is a little bit more mobile. And then that turns into a more arthritic pathology as that disc loses some of the height, and then it becomes hypomobile. So what we're going to talk about more is the hypermobility. So how does that relate to the thoracic spine, right? So think of the lower cervical and the lower lumbar as those weak links like we mentioned earlier. The body always does what's easiest. So just like in the throw or just in day-to-day life, if something doesn't move or something is weak, the body is always going to achieve that motion, and it's always going to go through the path of least resistance, right? So that disc degenerates in the cervical spine, that disc degenerates in the lumbar spine. So when we twist, move, rotate, that's where all that motion is going to go first, and it's going to go most, and then it's going to go into that stiffer part, right? So what we see in the thoracic spine is more stiffness and ultimately more weakness, right? So if the body always moves in the path of least resistance, what we need to do is take the pressure off of those hypermobile segments by mobilizing the hypomobile segments to take the pressure off of those areas, reduce pain, and then ultimately strengthen it to improve our movement pattern. So that's what we're going to talk about with the thoracic spine as a way to, you mobilize it to take the pressure off the neck, you mobilize it to take the pressure off the back to reduce pain. And then in terms of throwing, a limited amount of rotation. Think of if you're a right-hander and you're looking at the batter, right? So if you have a limited amount of rotation, normally what we see is a limitation both in the shoulder, thoracic spine, hip, hamstring, but it's usually unilateral, right? So we're always biased to one side. If there's a reduction in rotation of the thoracic spine, then either the windup or the follow-through are going to be limited. And normally what we see, especially with right-handed throwers, is we have more rotation to the right for the windup, but then that follow-through is more stiff, and then that's going to change the orientation of the ball and put more stresses on, just like the neck and back, the smaller structures, the areas that can't really take that load, and that's how we get elbow, medial elbow, and anterior shoulder pain. All right, so what we're looking at here is a spine model, looking at the thoracic spine. So thoracic spine is made up of 12 motion segments, 12 vertebrae, 12 ribs on either side. You got the nerve roots sticking out, and then the disc in the front. So stiffness or hypomobility is normally seen in the upper portion and the middle portion. Sometimes in the lower portion, but historically it's that upper and middle portion, and that's really important for neck patients, right? So if you have that hypermobility in the lower neck, that hypomobility where that neck meets the upper back, and then so on. That's going to lead to a limited amount of motion in that region and put more stress on that cervical spine. So the first stretch that we're going to do is a facet traction. So basically what we're doing is trying to separate each motion segment from each other to help improve all motions. That's what facet traction does. So we've probably seen this before. We're going to lay on that foam roller. So the foam roller is a cheap and easy way to do this at home. Not the best because of the size, but pretty effective. So we're always thinking about the other body parts, right? So if we have a hypermobile neck, a hypermobile low back, we want to stabilize that either through muscle activation or through our hands, external support, to not put stress on that area. We never want to stress an area to stretch another area, right? So we're going to lay on the foam roller, usually like mid-back, bottom of the shoulder blades. Lower back, you're going to do a posterior pelvic tilt. That locks that low back out, puts it more in a neutral position, and then you're going to support the head. We're not going to arch over. Each area doesn't move very much. We're not going to arch over it. We're going to remain more flat. Neck is relaxed. Low back is neutral with our pelvic tilt. Bridge up a little. Do a big sweep. Go from mid-back, upper thoracic rather, middle thoracic to lower thoracic. Feel the areas that are tight. And then focus on individual ones, right? So maybe we spend 30 seconds or so in the upper thoracic, 30 seconds to a minute. Then we move to the lower or the middle thoracic, and then sometimes to the lower, but normally it's a little bit looser because we like to self-manipulate, like to self-mobilize, and then that area is closer to the lower back, so usually it's a little less mobile. So the benefit of a foam roller is its width, right? So the width of the foam roller, it hits a lot of soft tissue, hits the ribs, but as you can see, right, it spans 3 segments. So it's not the most specific thing, but again, a cheap and easy alternative to help start off mobilizing that thoracic spine. So now that we created a facet traction, now we want to reinforce that with a motion, right? We're going to work on extension now. So again, what we want to do is focus on each individual motion segment as best we can. Other tools that might be a little bit more effective or might be an alternative, a pool noodle works really well. In the clinic, a lot of times I like to tape tennis balls or racket balls together, and that is more close to a motion segment. But we're going to stick with the foam roller. So you're going to get in that same position. So we just rolled it. We created some facet traction. Now we're going to create extension at the areas that we felt and needed it, right? So same thing. Low back is tight through that pelvic tilt. Neck is supported. So we're going to try to create the extension at each individual segment, right? So if I just arched over it, see how I get motion through my whole back? That's because I'm more mobile in my lower back. So that motion comes through the lower back first and then into the upper back. So we got to create that, we got to tighten that up with that pelvic tilt, and then it's a little motion, right? So we're thinking about that lower vertebrae of that motion segment, right? Say here we're at T8, T7 is extending a little bit over T8, just until I feel that stop. So I'm not going, this is not a huge motion. Each vertebrae doesn't move very much, but we're working on reinforcing what we did with the rolling with now some active motion. About 10, roll down half an inch, same thing, and so on, all the way up to the top. As we get higher up, because of the curve of the back, that's probably when I would use that tennis ball or pool noodle. After the extensions, so we did facet traction, we did the extensions, now we're going to move into our third self-stretch of our thoracic circuit. We're going to work on rotation. So just like the extensions, what we want to think about is our neck position and low back position before we stretch the thoracic position. So what we're going to do, we're going to put our low back, instead of using the pelvic tilt, we're going to use what we call a soft lock. So the back moves in 2 different ways. It moves in an easy way, so a combination of motions of flexion, side bending, and rotation, or extension, side bending, rotation, and then a way where the bones or the joints don't really move as easily. So that's what we would call a soft lock. We're putting tension in that low back so that when we rotate, we don't take up all the slack through the more mobile segment. So what we're going to do, we're going to use a towel roll of any kind, sweatshirt, something like that, and we're going to put that over on the side of the floor opposite of the area where we really want to focus, right? So we're going to work on rotation, both directions. The towel is going to create a side bending, and then our legs are going to be up in a flexion position to create that soft lock. So wherever we want to mobilize, we put that towel roll under. Our leg is going to go up on the foam roller, like so. Foam roller works really good for this. It's usually the same height as the hip. Hand on the floor side is going to go on the leg, keep that leg there. Neck is supported by the hand. I see a lot of people do it with the arm straight, and then you open this way. Not a huge fan because of nerve tension. You're also just letting the neck hang out, which is, again, we want to support the neck. So hand's going to support the neck is passive. So we're going to close the book, and then we're going to open the book. So here we get a nice pec stretch. We're feeling all the motion above that towel roll because of that soft lock. So that leg being up also creates a lot of pull in the low back through muscle tension. Breathing, open up, back. So we do about 10 each direction. And then you can move the towel roll up as you want. We do it both sides, usually 10 times a piece. If you want to be more specific, again, add the towel roll. So what we're talking about when we say mobilize the thoracic spine is we're creating a facet traction, usually, of each segment, right? So we got my hand here. These are the two joints. So each joint in all the body, they have a capsule. The capsule is what holds that fluid, right? So when you hear a pop, what you're feeling is a stretch of the capsule. So what we're doing is not putting things back in place. We're not adjusting things. We're stretching the capsule. So what happens in the thoracic spine a lot of times is a weakness impairment. So what happens is we have a lot more motion in our neck, a lot more motion in our back. Because of our day-to-day lives, a lot of people sit, a lot of people are inactive. We fall into that forward posturing, right? That upper back gets tight not only because of a stiffness, but more importantly because of a weakness, right? So we're not using the muscles in that upper back. The fluid in that joint, in that capsule that we just spoke about, doesn't move as easily. It gets more stagnant, and then that creates a stiffness. There's muscles that stabilize, and then there's muscles that move. So the ones along the spine, if they're not active, or a lot of times with low back pain, neck pain, what you see is those muscles actually start shutting off and become fatty. So they're not moving, they're becoming inactive, they're becoming pathological. So the bigger muscles, like the parascapular muscles, as we're talking about the neck again, levator scapula, the paraspinals, they turn on to do the job of those multifidus, those rotatories, those ones that are more postural. So we fall into that forward posture, the fluid slows down, and we become stiff. So what we have to do, we have to mobilize that area. You get a pop, that's fine, clicks and pops. It doesn't need to have a pop to make a stretch, but you mobilize it and then you strengthen it. If we don't strengthen after the mobilization, then our body's gonna fall back into that poor motion pattern, that poor movement pattern, and it's just gonna be the same as it was before, right? So we mobilize and then we strengthen. Hey guys, thanks for stopping by. Hope you enjoyed the video. If you want to see more videos like this, if you have interest in more videos like this, like the page, you can visit our website at overheadathletics.com.